Hello and welcome to another episode of Face to Face. My name is Godfred Akoto Boafo. My guest today is a medical doctor. Turns out he's also a lawyer. And he is also the General Secretary of the Ghana Medical Association. Dr. Justice Yankson is our guest on Face to Face. Welcome back to Face, and welcome, Dr. Yankson.
Thank you, Godfred.
At this point in time, at this time of the day, these are not the kind of circumstances you expected to be experiencing as a medical doctor. COVID-19 seems to have changed the face of medical practice this year.
Well, to an extent, yes, but for us, it's still the same work.
And what has been the overview, basically, of the Ghana Medical Association so far of what has been going on, the way Ghana has handled this so far up to this point?
Well, to sum it up, we can say that by and large, we've taken some good steps. There is always a debate as to whether some of the steps should have come a bit earlier in the day or otherwise. But whatever it is, some of the steps are yielding fruits. And we think that it is in the right direction. But we also believe that certain more steps need to be taken to help us contain the disease. But of course, there are the general issues to do with care at the facility level, the safety of the health personnel themselves, issues of that nature. So I'm sure as we go into the discussion,
yes, we will get into that. But when the COVID-19 was raging on in a place like China, where medical professionals here, doctors for that matter, worried? Or were they observing what was going on there? Or at that point, we didn't think this was something that was coming our way?
Well, when it started, we were all observing to start off with. But it got to a point we all knew that sooner than later, we're going to have cases on our hands as well. The truth is that pandemics will always start from somewhere, and then it will keep escalating. But the point at which the WHO declared it as one of public health importance, then the whole world knew that, look, it was just with all of us. It was just a question of time, and everybody was going to be caught up in that net.
Can you walk me through the process? So when things like that are happening, do you call colleagues in China and Europe and say, hey, how is this thing going? How do you handle it? Or you just wait for your turn to participate in it? Were you making calls and stuff like that?
To start off with, coronavirus per se is not new, except that this strain or subtype we have is a novel one, so we agree. But by and large, we communicate amongst ourselves as professionals. So if you have colleagues in China, you talk to them. If you have colleagues in the US, you talk to them. Some are good enough to share what they are doing at their end with you. We also have some international platforms like the World Medical Association, which basically encompasses a vast majority of the professionals the world over in terms of nations, who are affiliated. They also publish some information. The WHO will publish information, and then your own classmates, friends who are elsewhere practicing are ready to share what they are doing at their ends, all in an attempt to combat COVID-19. So in terms of the space, it's been good. On the African continent, there are some groupings as well, and we are also sharing information. So by and large, there's information sharing.
Was there a certain level of proactiveness from your side with regards to because we did get to that point where we realized it was just a matter of time before Ghana recorded the first case? Was the Ghana Medical Association ready?
As far as the Medical Association is concerned, I'll say by and large we're ready. The truth is this: we have our infectious diseases committee. Anytime there are things of this nature, they go to work. So even before we recorded our first case, that committee had started work, and we were preparing ourselves for what was to come, at some point in time.
Oh, okay. And I monitored the press conference that happened today. If you look at the cases around Ghana and where Ghana is now, is this the best way we could have responded?
Well, for the decisions that have been taken in recent times, generally speaking, we should have taken them probably a step earlier, but it is still okay. I mean, if you look at what happened today, it was quite significant.
Okay, how so?
The issue is this. The country, upon the advice of professionals, gets a decision to be made, i.e. the president announces that there's going to be a shutdown or a lockdown of our borders. And then a decision is also made that we need to quarantine people who are going to arrive within 48 hours of the ban. Hitherto, we were not doing these things. We pick 1,030 people into quarantine. We start the testing processes. We do 185 of them, and out of the 185, 25 of them are positive. Roughly a percentage of about 13 to 14%. And that is quite significant. Mind you, the people involved were selected randomly. It is not, we are testing everybody, so it was not as if we knew that Mr. A or Mr. B was going to have the virus or not. But we were going to test everybody, the whole 1,030, so we just started. And out of the first 185 to be tested fully, 25 of them were positive. Now, if you look at that particular number, 25, and then you benchmark that with what we had recorded previously for the past almost 2 weeks. In fact, 12 days. We started from the 12. So it's not even up to. Then it's like just in a day, we've recorded 50% or 100% of what we had. Previously, we had 27 as reported, 2 deaths, 25 are still under treatment. And then we get another 25. So basically, we doubled our numbers. And we hope that the over 800 plus yet to go through the full, testing regime, we don't end up with something higher or even close to this. Then it means our cases are going to shoot, up so high. Yeah. And that sends a bad signal. If you look at what happened to places like Italy and the rest, they also started with very small numbers. 2, they moved to 3 within a week, 8 after 2 weeks, and now look at what is happening. What it tells us is that if within a 2-week space, we are moving from 2 to God knows whatever the numbers are going to look like after we've gone through the 1,030, the rest of them, the 800 plus. If you follow this tangent, then it means our curve, the rise is going to be that steep. And what it means is that we need to put in stringent measures to contain. Luckily for us, all these cases are already under quarantine.
Yes.
And are going to be moved straight into the isolation centers for treatment. What it means is that we have, to a large extent, limited community contact and potential spread. And that is one good thing that we have been able to do out of what has been done so far. This is very remarkable. Yeah. And I think it is going to save us a lot as a country.
You touched on how the fact that we were able to contain these persons whilst we did these tests to get these numbers. There are those who also say, let me put the question this way, should there be a fear of those who went through the system for the past 2 or 3 weeks before these guidelines were put in place? After 2 weeks, if nothing has manifested, should people consider themselves safe? What kind of education can you provide?
Well, once we are getting into the era that we, as a country, have decided to go on, i.e. test, as being directed by the WHO, once we are done with this particular set, the 1,000, if the numbers continue to be in this ratios as we are seeing, the percentage, then obviously it may be necessary to probably even look back and see if we can get to all the people who may have passed through the airport a week or even sometimes more before the ban itself took effect. that way we can go ahead and test these people and potentially their contacts as well.
Okay.
Yes.
Can you run us again, since you're a doctor, can you run us again through the symptoms that people should look out for, the combination of symptoms that people should look out for? And for those of you who are watching at home, I know you've heard this a couple of times, but every time we have a medical professional, we will try and insist on understanding this all over again. So what should people at home look out for? And this is for those of you who perhaps have come into contact with people or came in before the mandatory quarantine guideline was put in place. How do I know that I should report to a hospital?
Okay. We should try and break a few things down. Mm-hmm. Ghana had a case definition that we were working with. In as much as it's more for the clinicians, it is also good for the general public to know. Now, we started off with a situation where we had, first, you needed to have a history of having moved from another country into Ghana, especially countries with the condition. And then we'll then look out for other things like, they are basically all respiratory, symptoms. So we talk about cough, we talk about sneezing, we talk about what people describe as catarrh or cold, and then difficulty breathing, together with a high temperature. So what people usually say fever. And in our jurisdiction, the cutoff was supposed to be about 38.5. But now we are saying that anybody with a temperature of 38 upwards, we need to look at. Now, with the coming into being of what we are now describing as the community spread or community infections, these are people who had not traveled elsewhere. Mm-hmm. They were in Ghana, but have actually developed the condition, COVID-19, out of either contacts with the infected persons or some infected surfaces. Mm-hmm. For which reason they have also fallen victim of COVID-19. So now it is not left to people who have traveled only into Ghana from elsewhere, but anybody in Ghana who now develops a fever, a cough, difficulty breathing, catarrh, and sneezing. These are things that should point to that direction, that look, contact the health professionals together with a fever. You may not exhibit all of them. Okay. You may also have some general malaise as well. General malaise, you just don't feel well. You may not exhibit all the symptoms as described, but of course, once you have a couple of them, and especially if you have a fever, then you are somebody we need to look out for. That does not necessarily mean that you have COVID-19. Truth is that even before COVID-19, these symptoms, we were all aware of them as symptoms for general respiratory illnesses. So it could have been a pneumonia, all the technical words we use, bronchitis, all the things we talk about. So the key thing is that now we have put out some call lines. Contact lines 112 is the easiest. Mm-hmm. You call through the contact line, and then after you've been spoken to, the health professionals, if they can assess you, will come to your end. We don't want people to be running all around and in the process end up infecting people whilst trying to seek care at the hospitals. So if you have any of these things, the best thing for now is to call. But if you can get easy access to a doctor or a health facility, you can quickly take advantage of that.
It's important that I ask you this, though. Once this started becoming a worry for a lot of Ghanaians, because initially it looked so far away, then Nigeria got one, Togo got one, and people were like, okay, this thing is getting close. And the general symptoms had been put out there. Did medical professionals in the various hospitals, did you get reports of people perhaps suddenly showing up with the... Did you get an increase in perhaps OPD cases where people just show up because they feel they have this disease, or was calm?
Some persons showed up out of concern. We took them through the processes. Those that we suspected could be suspected cases, as in those who fit the case definition. We decided to do what we had to do, i.e. get them tested and all that. And the first about 40 samples that were tested in this country, all of them proved negative. So people were coming in. But of course, we also had in mind that it is not everything respiratory that is COVID-19, but it is good to have that high index of suspicion. That way, nothing filters through the net.
Oh, interesting. Now, let's talk a bit about the doctors themselves, okay. Those at the front line. That is the group that you represent. How prepared are doctors for this across the country?
Well, let me put it this way, that generally, doctors are prepared. They understand the disease to the point of the information that is available. Mind you, this is novel. This particular subtype or strain of the coronavirus is novel. So information keep coming to us, the health professionals. We have our own professional websites and bulletins and journals that we get information from, even outside of the social media ones we all see. So as far as the disease is concerned, every doctor, to the best of my understanding and knowledge, has knowledge to be able to, in quotes, identify potential cases and work on same. But because of the nature of the virus, we also need not contaminate ourselves in the process. Yeah. So there are trainings that are ongoing. I must say some of the trainings are coming a bit late. But whatever it is, the nationwide training has started. They are now at the regional level trying to train, as many of the doctors as possible to especially be able to practice such that they themselves are not contaminated. Because if a doctor gets contaminated or infected, it is a very, very serious thing we are talking about. He has the potential to pass the disease on to patients and then the workforce around him or her. So we are doing our best to ensure that the doctors themselves put up the best of practices in their places of work, such that they do not get contaminated. We know health professionals are always at risk when we find ourselves under these circumstances. The first doctor who actually picked this whole coronavirus bit out in China ultimately succumbed to the disease. So we know that we are a very high-risk group, but this is our call to duty, so we'll have no option.
We've heard whispers, none confirmed though, of initially when cases came through. We heard the Kolebu whispers. We've heard some at Konfanochi. We've heard some at other private facilities where even suspected cases come in and doctors run away.
Well, let me be honest with you. You see, sometimes, I don't know whether it's the powers that be, the health system itself, but we take things for granted. We have provisions in our laws that mandate the general workforce, including doctors and all other health professionals, to walk away from danger when they feel that their personal safety has been compromised. So if you want a doctor or a health professional to go attend to a suspected case, the first thing is that you provide them with the requisite PPEs, the protective equipment that we talk about, that will enable them, in quotes, not get contaminated and ultimately become infected with the disease. But so if they are not available, of course, you won't get people seeing danger and just walking straight into that. Some of these things are happening because some of the facilities were not prepared at the time. But now, the facilities, most of them have put their houses in order. The practitioners know that by and large, these things are there. The right teams have been set up. Under these circumstances, you don't also throw everybody into the mix. So you put up teams who are responsible for some of these cases. So somebody at the OPD may just pick up the case, but from that point onwards, the suspected case is handed over to the teams that have been set up, such that the samples will be taken, the testing will be done, the case management itself will then also start. Yes, so now that a lot of the facilities have put the structures in place, we seem to have a lot of calm. But the professionals are still complaining, and rightly so. They don't have enough of the protective equipment.
Now, speaking of that, we hear of frontline health professionals. And I also get comments from other doctors who are saying the way that disease is, perhaps everybody should be considered a frontline person, because somebody might show up at the hospital with a fracture. You'll think you are treating a fracture, but the person might actually also be exhibiting signs of COVID. Yeah. So perhaps now might be the time to say every health professional should be protected with the PPE, irrespective of who they are treating, until the disease is dealt with. What is your take on that?
Well, for now...
Oh, that's an extreme.
No, it's not an extreme per se, but we need to go through some protocols. For now, the definition of a frontline health worker starts all the way from the security end through the records to the nurses' desk to the doctor's end. So basically, everybody in that value chain is now a frontline health worker. Okay. Once you come into contact with patients or you came into contact with a confirmed case, you are part of the frontline workers. Initially, people felt that the special groups that had been set up to deal with case management and what have you are those who are going to be described as the frontline health workers. But in truth, it involves everybody, because cases can pop up from anywhere. Yes. Okay. And when you get contaminated, everybody in that team or shift who was part of the group will have to go through the process of quarantine and then the subsequent testing and what have you to ensure that the health professionals and other key staff within the hospital themselves are not also contaminated, such that they will end up spreading the cases to the patients. And it's also instructive that at this point, especially places like the OPDs that are highly congested, we do our best to decongest them. That is not to say we are not going to provide care, but it is in the interests of the patients themselves. If you go to a typical OPD in our setting, you have loads of people come together. We are not talking about social distancing, but the phrase now is physical distancing.
What's the difference?
Physical. You know, the social sounds more like, oh, well, we are socializing and there are people here. But now we want everybody to take that responsibility, that ensure that your good self, you are physically distant from others.
Interesting. Dr. Justice Yankson is our guest on Face to Face. We'll take a break. When we return, he'll give us more education on how the Ghana Medical Association is prepping to handle the COVID-19. Welcome back to Face with the General Secretary of the Ghana Medical Association, Dr. Justice Yankson, discussing health professionals in Ghana and their preparedness to deal with the COVID-19 disease, which earlier on today we heard now had affected 52 people confirmed. That is from the Ministry of Health, the Ghana Health Service in the country. So, Dr. Yankson, we're discussing how health professionals said. Let's talk about facilities. Now, at the press conference, we heard the ministry talk about opening up lab spaces. That's not a space that you work in, so I'm not going to go there. But let's talk about the treatment facilities. If you want to speak about that, I'll allow you. But let's talk also about the treatment facilities. How ready are these treatment facilities we are talking about? Because I read about some of the cases in the US and other places, for instance, and the definition of this disease is such that as soon as you are struck down hard, you require a ventilator. These are things that on the basic, we know we don't have a lot of in this country. Do we have 52 ventilators?
Okay, now let's start this way. The lab space actually accommodates medical doctors.
Okay.
They are doctors whose specialization is laboratory medicine.
Okay.
Prof. Ampofo, for example, leading the Luguchi bit, is a medical doctor. There are a lot of medical doctors who work in the laboratory. So that laboratory space is not just for, in quote, laboratory technologists or scientists, but there are doctors who also operate in that space as well. But that aside, if you look at what is happening now, at the national level, we seem to, in quote, be quite prepared. it is the facility level, as you go down to the district, sub-district levels, that we are struggling or we are still trying to put all the structures in place. Now, at the national level, if we also don't take time, we'll be overwhelmed. We were all made to know that Rage and Tema were the main treatment centers. As of now, the cases have outstripped the capacity of these two places. Last week, Friday, luckily, I was part of a team that did some inspection of the new hospital around Kwabinyaga East.
Yes.
Yes. That hospital generally, because it is new and has not been used, by and large, is fit for purpose. There are a few, ventilators, and some places could still be, adjusted one way or the other to accommodate a lot more ventilators, such that if need be, we can use them. But let me describe the scenarios well. Mm-hmm. The disease, when it strikes you, you end up with what we call a mild case, a moderate, severe, and critical.
Okay.
Usually the mild to moderate people, you can manage them without ventilators. It is the severe and critical group. Those are the ones that will need a ventilator. But of course, you can never predict who will go into that category.
Exactly.
So you have to be prepared. And truth be told, as a nation, if the numbers rise to their thousands and we have a lot of people who need the ventilators, we are going to be overstretched. That is a fact. But, well, as it stands now, efforts from what we know are being made to procure. These things are also not produced there. And somehow there's a shortage the world over as well. Because these countries who manufacture these things are also struggling to get some for their own patients.
Countries.
New York alone had over 3,000 ventilators. And in no time, they were all underused and they were struggling to get ventilators. So, because we have not invested properly into our health systems, we have been caught pants down. Our hope is that we wouldn't have a lot of these. And then beyond that, you need specialized doctors, especially those in anesthesia, the anesthesiologists, to actually handle these centers. These are high dependency units, intensive care units, you need such people who are highly skilled to manage them. Unfortunately, our national count of such professionals is also nothing to write home about. So beyond the physical infrastructure, i.e. the ventilator itself, the human resource to ensure that they are properly used for the benefit of the patient is also in short supply.
Speaking of the human resource, we had heard mention that there would be a mobilization of perhaps retired medical personnel, experienced professionals, perhaps those even on steady duty if need be. Is that a process that you are aware of? Are you involved? The Ghana Medical Association, I mean?
Well, we have heard, and our response to this is in twofold. You can talk about different classes of retired doctors. For those who don't really need to be in the clinical setup, i.e. people who are epidemiologists and what have you, who can advise without necessarily being in contact directly with care, the clinical bits, I think their experience will come to bear under such circumstances and will be useful. But when it comes to the clinical components, we need to be careful who we select to be part of the frontline team.
Why?
Because as we know, the disease actually is more virulent when it comes to people who are elderly and also have underlying health problems. As human as we are, most people tend to get some of these, non-communicable diseases like hypertension, diabetes, or cancers, what have you, that can compromise your immunity as well when people are in the 60, the older age groups. So if you have a population of that nature, and you find a lot of them probably with a lot more of these comorbidities, like all the things we've mentioned, the hypertension, then you also put them at risk. It is a time of crisis, but if you have to fall on them, we may have to tread cautiously and select carefully It shouldn't be a wholesale activity.
At this point, we have to tread cautiously.
Yes, because
the fact that they are qualified medical doctors alone should not suffice.
No, the first group of people I think we should be looking out for are those who have completed school, they've passed out, but are home because of
okay. So they're unemployed.
The financial, doctors, nurses, what have you. The older generation, like I said, we should be very circumspect the way we use them.
Okay.
Yes.
Thank you very much. Now, you spoke about the treatment process for this when we're discussing the facilities. Can you walk us through what the process is now? It seems like a lot of hope as the main drug right now. Is that what it is? Is that a correct assumption to make?
Okay, so the treatment process, what happens is that if you test positive, so we are talking about somebody who has gone through the system and has now tested positive, confirmed. Now, once that happens, the news will obviously be broken to that patient, and then the patient will be walked through the processes for them to understand what is going to happen. They are then moved to the treatment center. The treatment center could be in the facility where he or she was diagnosed, because usually what happens is that if you walk into a hospital, the right thing to do is that when you suspect the case, you hold the person in that facility. The samples are taken there. The samples are sent to Noguchi or KCCR. The results finally are generated, and then it is passed on to the facility within the chain. The facility then will have to trigger the next process. If that facility can handle cases, or it's a designated center for handling cases, they will have to handle the case there. But if not, then they will have to move the patient with the use of ambulances. We are training the National Ambulance team to be part of this whole exercise. So they are dedicated ambulances that will pick the patient from that location to the treatment center. Now, sometimes, at least for now, some of the cases are also being managed at home. Okay. These are people who have the right environment for the care, the isolation to happen.
What is the right environment?
Okay, so when you are being managed, let me take the opportunity to explain these two things, yes. Quarantine and isolation. Quarantine, you are suspected to have come into contact, or potentially you could have come into contact with the disease one way or the other. So we put you under quarantine for a certain number of days, usually 14, plus, depending on what the situation is. And then the samples are taken and all that. So like what is happening to our brothers who came from elsewhere into the country. Then we have the isolation. The isolation is where you have tested positive. You are isolated from everybody. So you are in like a cubicle room, okay, sort of, where you have your basic facilities, toilet, baths, and then you are there alone with the health staff to manage you. But of course, if it's a bigger, spacious ward, you could have quite a number of people on the ward, but that's some distances apart. Then the doctors and the healthcare staff take turns to go and see the patient and then provide their needs. Now, for those who have, let's say, their own homes where they can actually be in there all by themselves without other household members coming in, and then also have what we call the mild form of the disease.
Okay.
They, because of the lack of resources and everything generally, we are able to manage them in their own setting. But of course, they don't go out. Nobody interacts with them except the health professionals. Yes. So they go there on a regular basis to visit them, to give them their medication, to check on their vitals, their temperatures, all the things we do. So basically, that is how the nation is managing cases now. But by and large, the plan has also now shifted from the situation where we had designated treatment centers, like initially communicated. Now we are roping in the regional teaching hospitals and even the district hospitals. So basically, facilities are to ensure that they have places where they can manage patients. But for the critically ill, they may be moved to the centers where the few, ventilators that will be available will be deployed. So it's possible that you could be moved from maybe Kaswa to Rage or Kolebu, if that is where a ventilator is available. And at that point, you need to be put on the ventilator. Usually you have about between 5 to 10% of the patients, looking at what is happening worldwide, who will require these ventilators.
Okay. Now, let's talk a bit about recoveries. And that seems to be a stat that bothers Ghanaians a lot, because when you go to even the Johns Hopkins database, you see the confirmed numbers, you see deaths, and then you see recoveries, which is always green. We've had, until today, we had 20-something cases, 24, 25 cases, 0 recoveries.
Yes.
Why is it? Why are the recoveries taking so long?
The issue is this. We just confirmed our first case 12 days ago. So technically speaking, treatment for such people is under 2 weeks. Okay. Now, you need to go through the treatment for a while. We need to test you, retest you to the point where we can say that the test results are showing that you are no more positive, but rather negative. So you need time to get to that kind of, situation. And because the disease has been with us for just a little under 2 weeks from the date we confirmed the very first case, we are not in a situation to talk about recoveries. But what we have seen per the clinical management is that the patients are recovering. Of course, we've lost 2. And they said that they had comorbidities and whatever. But truth is that death is death.
Okay. Now, we've also heard talk of certain drugs that help with this. And because of the era in which we live in, once it was announced somewhere, and I'll be specific here, somebody mentioned chloroquine in the US, and in Nigeria, I heard yesterday, for instance, somebody went to take chloroquine and died. In the US as well, somebody has taken chloroquine and died from it. In Ghana, we are hearing people have started stocking up and showing up at pharmacies asking for chloroquine. Can you advise on this particular issue?
Okay. Now, what is the truth is this. One, chloroquine itself is a banned drug in Ghana as of this point. But of course, we can employ it if need be. Originally, chloroquine was registered or licensed by the FDA for the treatment of malaria. And then somewhere 2005, it was delisted because we realized that its efficacy and all that had reduced. That was at the point at which we introduced the ACTs, so all the co-attempts, all the bits we talk about. So that combination therapy is what we are using for malaria now. So chloroquine itself had been taken out. Now, some researchers, especially in France, try to do some work. It doesn't meet all the WHO or scientific standard. But what they found, by and large, was quite encouraging to the scientific community or the medical community.
Okay.
And they did a combination of what you are describing, but not necessarily chloroquine. There's something we call hydroxychloroquine. There's a slight difference between chloroquine and hydroxychloroquine. This is the chemistry bit of it. Okay. And then another drug. I don't want to put all these things up because people, it's just that you had mentioned the chloroquine. So
yes.
Then another drug. That combination was done. And it seems to have given some results. Because it's a novel virus, we didn't have clear-cut treatment in terms of medication for it. But we also know that because it's a viral disease, some antivirals could help. And then the associated temperature and all that, we could use antipyretics to deal with them. So these were the protocols that some countries were employing to help deal with it. Now, for us as a country, we have just also agreed on what we are going to use for the treatment.
Okay.
That is for the clinicians. That I'm not going to put out here. But people should understand that one, what is being talked about with chloroquine as part of it is for treatment. It is not for prophylaxis.
What is prophylaxis?
Prophylaxis is like you're taking it to prevent you from, getting, in this case, COVID-19. No. So these things are meant for the treatment teams, the case management teams, the clinicians. They will then use the right dosages. If you just go out there to buy chloroquine, you might be taking overdose or an overdose of it, and you end up, like you said, somebody is passed on in Nigeria for, yes, because we just don't administer drugs to patients. Sometimes we even have to use their weight and what have you to decide on the quantities in terms of the milligrams and what have you to give. So the dosages are related to specific indices within the patient, and these patient factors will have to be taken into consideration, and sometimes as well as other comorbid conditions that they are managing. Some of these drugs may even interact, and the interactions could be good or bad.
Okay.
So in the clinical setup, we just don't use drugs anyhow. And I think that people should stop chasing after chloroquine. We've actually even heard reports that in some villages, people are selling chloroquine. And our suspicion is that it's even a fake product, because this is something that has been out of our
medical system
for almost 15 years or so. So if somebody comes to you peddling something and telling you it's chloroquine, you must be very, very careful.
What about herbs?
In fact, as far as the WHO is concerned, at this point, there's no room for herbs. Look, the WHO is leading the way, and we are all trying to follow the scientific community. Let's cut out all the externalities and the alternate bits that people are talking about. Let's follow the right principles. The WHO keeps updating everybody on daily or hourly basis. We have the universities, the research centers, the world over, all trying to get to the bottom of this, because the disease has been with us for about 3 months. I mean globally.
Globally, yes.
And that is not long enough for everybody to get all the characteristics of the disease and the virus itself. But by and large, the scientific community is basically doing quite good, and we are relying on, all that the scientific community is giving out, including Ghana. Ghana itself is also studying, the virus. Once we have cases here, Noguchi and others, our research scientists are also at play now, looking at the disease in detail. Okay.
Now, let's also look a bit at those who are the most at risk. Now, if you look at the data from Europe, you'd realize that it's those, the 65 and above age range.
Yes.
Africa, we are quite young. It's the youngest continent, they say. We have about 4% of our population being above 65. Some say that is an advantage, and perhaps that's also ensured a certain kind of recklessness in how Africans have looked at this and have not taken it seriously enough. What is your take on this particular perspective?
Well, yes, we may not have as many old people as possible compared to the other, continents. But truth is that you could find a 60 or a 70-year-old whose immunity is way, way better than that of a 40 or a 50-year-old. So it is not just about the age, but about the fact that, one, you may have underlying comorbid conditions, and two, your immune system may have been compromised even before the virus got to you. And to build a good immune system, a lot of factors come to play, including food or a balanced diet properly. We know that on the African continent, because of poverty, there are a lot of people who cannot say they get the right sources of nutrition for them to have the right, immunity, or the immune system that we are talking about. It might not be that robust. So if we just follow the numbers in terms of age, that could deceive us to an extent. But it is true that older people who are immunocompromised, have other comorbidities, are succumbing more to the disease than the younger ones. Yep. But hey, let the younger ones not think that that cannot also kill them.
All right, then.
Yes, the key things are that we should ensure that the preventive measures that are being churned out on a daily basis, we adhere to them.
All right, then. We'll take our final break. When we return, we'll complete our conversation with the General Secretary of the Ghana Medical Association, Dr. Justice Yankson. We'll be right back. welcome back to Face with Dr. Justice Yankson, General Secretary of the Ghana Medical Association. Doc, there's a question that I get on my social media a lot, and I'm still looking at it right now. Reinfection. Is there any knowledge on that? So far, I know it's a pretty young disease, but science also seems to be chasing it pretty quick. Is there any knowledge on reinfection?
Well, what we have come to understand is that there have been some patients who became positive for the disease. They were treated, and then at some point, they got the infection again. Now, what we are not too sure of is that, was it that it was a relapse of the first condition, or it was just that having gone back into the community, they reinfected themselves, all because they had not built up enough immunity during the first infection.
Okay.
So it is something that is a bit of a gray area. It's either a relapse or potentially a reinfection. And if it's a reinfection, then what it means is that in the first instance, they couldn't build up enough immunity out of the first infection they had to prevent a second infection. So that is where we are. It's a gray area. It's either a relapse or a reinfection. But there have been some reported cases of that nature.
Another concern is food, like where we purchase food from. What is the danger there? You know, Accra and a lot of cities in Ghana are places where people eat in restaurants and stuff like that.
This COVID-19 also requires us to observe some hygiene. Now, the spread of it is through contact. So a surface could be contaminated, and then you go in, you pick it up, ultimately through your hands, you end up touching your face, and then the orifices and the soft, membranes around the face are the routes for the passage of the disease onto the respiratory system proper. So if you end up in contaminated markets and food sellers joints and what have you, and you also don't protect yourself through the hand washing and the sanitizers that we are talking about, you could pick the virus from such contacts.
Okay. And let me also ask on this one, finally, to wrap up, best lessons that we have learned from all the other places put together. Some are saying, let's look at China. Some say Japan. Let's look at Korea. Put together at this point, what is the best lesson we have learned from this that we are taking moving forward, at least where we are now?
Well, where we are now, we are trying to do a lot of the preventive measures. There are two ways to the transmission. The vertical, which is the importation from elsewhere, and that is what we are trying to break through the measures that we've put in place, i.e. close all borders, so then you don't get new cases coming in. Now, the horizontal transmission, which is community transmission, we are beginning to see some of it, and we need to take all the steps to break them. So all the things the president has put out and the health authorities have also put out are all in order, but we need to do more. And there's this debate currently going on, i.e. whether to lock down Accra or the country or otherwise.
Yes, we've heard that.
And that is also one of the measures.
Is there a medical opinion on that?
You see, yes. What is the reason for the lockdown? The lockdown is to break the chain in that community transmission. That is the essence of it. So the decision we'll have to make it. Do we do it now when we have relatively smaller numbers of cases, or wait till we have the thousands? In my personal view, it's about time we did some partial. And what that for me is that we should look at the epicenters in our country now. It is Greater Accra region, Accra Tema to be specific, and then Ashanti region. We can decide to lock down these places, and then the exceptions will be the essentials. So essential services will run. Things like food, medicine, water should also run. So i.e. food sellers in the markets, we should allow them to operate. But things like the bruni warehouse and what have you, we can start thinking about closing all those bits in an attempt not to spread. For me also, if we allow this to fester on for too long, and we end up with a lot of cases before we decide to go on the lockdown, then what that will also mean is that we may potentially have people in the communities, even though they are not coming out, but they may be spreading the disease among themselves. Reason being that our communal living and the lack of housing in this country means that people will almost always be crammed together in a single room or maybe living in a compound house. So in as much as they may not be going to work, there's potential for that spread. And if we have a lot of cases in the community, you can never tell who has. So it's about time we take some quick decisions as to the way forward by way of enhancing the measures. We can also allow, let's say, for example, if you are doing Accra or Greater Accra and Ashanti region, what that means is that human movements will all be curtailed, but by and large, the exceptions may include, say, cargo trucks who will bring food from the hinterlands to. That way, what would have done also is that we would have tried to contain the disease, at least at this point, where we know it's Greater Accra and Ashanti, to those regions, and spare the other 14 regions as well. And if we are to go along that route, yes, we need the security agencies and all of them to come in. People may talk about the economic implications, but the truth is that, like I said, what is the reason for that enhanced activity? It is to break the transmission. If you do it now, there will be economic implications. If you do it later, there will be economic implications. But later, you have a lot of cases on your hand. Your medical system itself is stretched. And truth be told, we don't have a robust medical system like that of, say, Italy or the United States. And they are even overwhelmed. They are overstretched just because of the cases and sheer numbers. We don't have enough logistics. The PPEs, the essential, things we need in the health facilities, we don't have them. You are just mentioning ventilators. No matter how many we procure within this system, if we had hundreds and thousands of cases, we will not be able to, and we'll get to a point where the resources that we also have to go into other ailments will all be stretched. Yeah. So just like we took a bold decision to quarantine people and start doing testing, just the first year, look at what we are getting. So the principle for me now should be test, and then enhance the measures as much as possible, but allow some essentials to go on so that as a people we can still live.
Thank you very much, Dr. Justice Yankson. He's the General Secretary of the Ghana Medical Association. On this very COVID episode of Face to Face. My name is Godfred Akoto Boafo. I hope you have been properly educated and informed. Have a good day.